Hello, everyone, and welcome to our webinar. I'm Dimitris from Marketing Movemedics. The topic of today's webinar is acromioclavicular dislocations. We have Professor Funk to present. He's our expert. He will present on surgical technique, cases, and tips and tricks. Please be aware that we will have a Q&A session at the end after the presentation resumes. And please insert your questions in the Q&A area, and we'll be able to select questions at the end. Without further ado, enjoy, and I hand over to Professor Funk.
Thank you very much, and thank you for asking me to do this. I'm going to basically talk about the LARS ligament for AC joint reconstructions. Just my disclaimers, I haven't received any royalties from the company, and I've not been involved in development of the LARS ligament. I'm just a simple user. So why ask the simple user to do this? I guess they've asked me because I've been using it since 2008. So about 16 years I've been using this ligament. Done 397 cases over the last 15 years. Just breaking them down, I very, very, very rarely do acute, so 9% of them acute, vast majority primary chronic AC joints. 30% have actually been revisions. Of those, 76 first revisions, 36 second revisions, and even some third revisions. So the big deal about AC joints is that there's, as you know, over 100 published different surgical procedures, and really that's because there isn't a single good one. Overall, in the honest literature, there's about a 20% failure rate. So when I started out as a consultant, from 2001, it's the one operation that I changed so many times over 7 years. I started with the Weaver Duns. We even published arthroscopic Weaver Duns, went to the tight ropes, the surgery leg, and then hamstrings, which is probably what I found to be the best. But a lot of our patients didn't like us operating on their leg to fix their shoulder. I then came across the LARS ligament, which, as I say, I've been using ever since then. Another thing is the part of my practice, which has been tertiary referral, means that I've seen a lot of the failed AC joint reconstructions. So I needed something for the revision procedures. And I really only started using LARS for the revisions, but then my revisions were doing better than my primaries. So I started using it for the primaries. And, you know, that holy grail that we wanted was something that we could use for revisions. It was strong, anatomical, biological, ideally avoid a donor side morbidity, and I could use it in athletes for fast rehab and return to sports. Just going back to the basics, I think to realize that we taught traditionally the CC ligaments are for vertical stability and the AC ligaments are horizontal stability. But also sometimes we forget the delta trapezial fascia is also an important dynamic stabilizer of the AC joint. But the AC joints are, the AC ligaments are also very important for superior stability as well. Predominantly anterior-posterior, but also superior stability. So they're all very important. And like I say, the delta trapezial fascia is one that's often not thought about, but also needs to be treated and managed as part of your stabilization. If you look this is a paper from 2000 at the techniques that were around then, and they compared them biomechanically, and none of the reconstruction techniques at that stage were able to restore the normal mechanical function of the CC ligament complex when tested to load. This is a paper just published last month, but you may never find it because it's in a journal called Curious, which I never heard of before, but a fantastic paper done in Sheffield, and they looked at the common reconstructions that are done in the UK using synthetic ligaments. This was static loading, and they found that all the implants were fairly similar, as you can see, in terms of anterior, posterior, and superior, inferior, as long as you added an AC joint repair, so an AC ligament repair or reconstruction. I do recommend having a look at that paper if you can find it. But you can see that as long as you do that, the results are similar. So I'm not telling you this is the only thing to use. What I liked about it as well is that the CC ligaments are the strongest ligaments in the body per diameter compared to any other ligament at 500 Newton strength. So the beauty of the LARS ligament is it has a 1500 Newton tensile strength, which means you're covering that, which many of the others didn't do. The retrieval studies showed good vascularization and fibrous ingrowth, and they were shown to be very good to resilience and resistance with repetitive load. So it fulfilled all those criteria that I was looking for. So the nice thing about it as well is that it all comes in a kit with everything that you need for the reconstruction. You need very basic additional orthopedic instruments. The incision is a brass strap or saber incision extending from the coracoid to the back of the lateral end of the clavicle. The approach I like to use is one I learned from Angus Wallace and Lars Neumann in Nottingham, which is to take the deltoid and strip it off with a periosteal sleeve in that manner. And the nice thing about that reflection is it gives you an incredible access and vision, but also you can then do a reefing and double breasting of the deltotrapezial fascia, which is often stretched out or torn in most of these cases. So I routinely excise a few millimeters of lateral clavicle. You then pass the guide from the medial end of the coracoid. Very important, you go behind the pec minor insertion and open that up so you know you're safe, and then pass that round behind the coracoacromial ligament, as you can see there. You retrieve it with the loop, and we add an additional suture with the ligament through that, which we'll use later to add an additional figure of 8 reconstruction. And so there's obviously some concern or discussions around where and how you do the drill holes. I'll refer you to this paper from China from 2013, which looked at the isometric points of the coracoclavicular ligaments on both the coracoid and clavicle to give you some idea of the directions. And this is where they showed the isometric central points on each, on the coracoid and on the clavicular to give you that orientation on how they run, and that guides, for me, that guides where I put the drill holes and the direction of the drill holes. I think you've got to adapt it to the patient as well. The important thing is to make sure is that you have sufficient bone laterally and sufficient bone between your two drill holes so you don't get any cracks in the bone. So for softer bone and older bone, you definitely want more space between those drill holes. In terms of the orientation, the medial goes from anterior superior to posterior inferior, and the lateral is from posterior superior to anterior inferior. So aiming in that same direction that the ligaments run. You don't be careful to go too horizontal. So then we pass the ligament through the drill holes, and there's some nice passing wires to assist you in doing that. Once you've passed them through this stage, now it's very important to reduce the clavicle on the acromion. And there's different ways. We can always talk about tips and tricks for that. And then you pass the guide wire. Very importantly, you need to check that tension of the ligaments. It has to be nice and tight and well reduced. Also, just take the ligament under the coracoid, pass it side to side to get rid of any possible soft tissue underneath. But very importantly, make sure that you've got the tension right in those ligaments. When you're passing the screws, and remember these are interference screws, so they don't have a strong thread on them, so it does take some force to get them in. So when you're passing the screws, keep constant tension on the ligament to maintain that tension for when you let go. The other thing is you don't want to put it in too fast. You need to just go a bit, let the torque stresses relax, and then go a little bit more. And then you can tighten one and then tighten the other, just like you would do lug nuts on your car wheel. So that's the standard repair. Then one of the things that I found many years ago, by adding a figure of 8 loop under the coracoid again, it seemed to improve the horizontal stability, and also it gave an additional reinforcement in case there was any damage from the screws to the ligament, which, as I say, adds that extra benefit. So that shows you this is doing the figure of 8 and then tightening. And again, when you're doing that, you want to keep constant tension on both ends of the ligament. So this is the modification for standard procedures. You can also pass it through the acromion like this, which is a technique Joe De Beer published for hamstrings, which I did for hamstrings before I did the LARS. So I did the same with the LARS. You can do that. That I predominantly do for people where you can't get a nice AC ligament repair, or for a revision where there's poor quality. And that just shows the ligament there. So very importantly, in terms of closure, repair the AC capsule and the delta trapezial fascia. You can add an internal brace as well. Again, I do that for poor tissue quality, or you could do a reverse CA ligament transfer as well, which is, again, useful for poor ligament quality. So we tend to x-ray them at day 1, 3 weeks, 3 months, 1 year, 2 years. Post-op, it's a very strong fixation. So as you would if you've got a strong fracture fixation, you can start early mobilization. So they start active range of movement as comfortable. The main thing is no forcing or stressing, and then move on to sport-specific rehabilitation very early on. This is a rugby player. This is him 3 weeks post-op. You know, generally they have good active movement by 3 weeks post-op, and that's him getting back to play. So, so we looked, thanks to Julio, we looked at our LARS patients in 2014 and published them. And because we had a large number of athletes, we compared the athletes with the non-professional athletes. Essentially, the results were pretty much the same with decent results. You can always look up the paper. Like I said, with revisions, we add a few things such as a reverse CA ligament transfer or a reverse biceps flip procedure. Nowadays, almost certainly, I always add hamstrings autograft for almost all revision procedures. So we reviewed our revisions as well and published them. There was 23 cases there. The original techniques were common ones done in the UK, and you see that there. So in summary, I tend to do them open, now stopped arthroscopic. Importantly, as I say, repair all the structures. So you want to reconstruct or repair the coracotrabecular ligament, the AC ligaments, and the delta trapezial fascia in all cases. The LARS I found to be the strongest anatomical and biological. Nothing is perfect. Everything has failures. So don't let me tell you this doesn't have failures. It does. You can use standard or modified techniques and modify as needed according to the patient and the pathology. And I've presented our results. So thank you very much. We'll lead on to Q&A, which is probably more relevant for you experienced surgeons.
Yes, Dr. Funk. So we have several questions from the audience.
Yes, I'm just getting them up. Yeah.
You can read them. All right, please.
Do you want to field them for us? Is that okay? It might be easier than in case I miss anything. So,
yeah. So first question: is there any case that the clavicle tunnel accidentally bursts, and what should someone do if it happens?
So no, I've never seen it burst, but if you have soft bone and your screw holes are too close together, you can get linear cracks, either between the two screws, or between the lateral. So number one, if it's an older patient, definitely I would often get a DEXA bone density scan beforehand. Secondly, I would warn the patients that this can happen. Thirdly, make sure you leave sufficient space between the drill holes. When you drill, slightly over drill the superior drill hole. When you pass the screw, you make sure, like I said before, is that you let the stress risers settle. So you'll go a bit, let the stress rise, and go slowly and carefully. So that's the thing. If you've done all of that and you still get a linear crack, then what I'll often do is then take the ligament and then use it as a cerclage. So you take the ligament from the top drill hole, go under the clavicle, cerclage around the crack, the area of the crack, and just tie that and carry on as you normally would. Go a little bit slower with the rehab. They're usually older patients, so they're not athletes. If you are really worried and you think it's going to crack, the other thing is you can do it without the screws. So if I've done it in these sort of cases without the screws, and also some patients have very small bones. So, for example, in China and Asia, you may find that these drill holes and ligaments are too big for your patients. So you may want to consider just doing it without the screws and then use the figure of 8. So that's worked just as well in patients that aren't as high demand or as young. So sorry, that's quite a lot to answer, but that's the answer.
Professor Funk, a little bit of a clarification on that area. You've said repeatedly that sufficient area should be, left between the two drill holes. What would be a sufficient area? I mean, depends obviously on the anatomy, but could you suggest a safe ground?
So I'd say you need take your thumb, put your thumb down, and make sure that they're no closer than the distance between your thumb. And they should be wider than the coracoid, but you don't want to go far wide because that's non-anatomical. There's no problem if you do. I mean, one of my colleagues who's retired now, John Haynes, he used to put them very far apart. The problem with putting them far apart is you could end up going too close to the lateral clavicle. So, if you want a rough guide, no less than your thumb, the width of your thumb.
All right, thank you. Next question. Is it possible to use PEEK screws? That's a question.
I don't know. I mean, in theory, yes, but the LARS haven't made PEEK screws for this. There aren't PEEK screws in the kit. PEEK screws haven't been tested with this ligament or kit. So the simple answer is, in this country, no, because for those reasons. I guess in your country, I guess China, I don't know. But I'd be interested to hear their thoughts. So is it possible? Theoretically, yes. And I would love the company to actually develop and improve that aspect, because you're highlighting that is an issue. The screws are also a little too long as well. So that could be a problem. Watch out for that if you're doing smaller patients or females, because I have, at least in one case, I've seen a case where the screw is impinging on the coracoid and causing pain.
All right, thank you. Next question. Any screwless surgical technique from your side, briefly? Again,
like I said, and that's a really very good point, is I have done it screwless, absolutely. However, again, that's not been biomechanically tested. I'll stop sharing, actually. My screen is going all weird. So the difficulty is it's not been biomechanically tested. It's not been approved as the standard technique. I have done it on a risk versus benefit basis to avoid fracture where the bones are too small. So the simple answer to you, Mr. Anonymous attendee, is yes. And that's your judgment decision, and I have done it.
All right. Next question. Does the acromioclavicular ligament need to be fixed or repaired?
Something's going weird with my screen. I can hear you fine, but I don't know what you're seeing.
We're seeing you, Dr. Funk, Professor Funk. It's fine. That's perfect.
Okay, great. I can't see the question. So sorry, what was the question?
Yeah, so the question is, does the acromioclavicular ligament need to be fixed or repaired?
Yes.
It needs to be.
Well, same thing. It needs to be repaired and reconstructed, and depending if it's good quality, if it's an acute case, then you can do a repair. If it's not great quality, then you could do any form of internal bracing that you fancy. So you could put anchors, drill holes with a figure-of-8 tape loop, or you could do a CA ligament reverse CA ligament transfer, or you could use the LARS ligament through the acromion from the lateral hole. But yes, absolutely essential that you repair or reconstruct the AC ligaments.
Okay. Next question is how about implant removal? Do you use it routinely or not? Not if not needed.
Not needed.
So very early you do a removal, only in case of revision, I guess. I assume.
Yeah. Or sometimes you might get, because you always get some degree of osteolysis, and that's natural with any synthetic ligaments that you put in bone. So you get some degree of osteolysis. Sometimes you can get the screws to be loose and backing out, and if that happens, you can take the screws out.
Okay. So how about distal clavicle removal? How much do you remove? And you said you routinely remove. Is there an algorithm there for you?
5
What's your
millimeters.
decision?
As little as possible, 5 millimeters.
And what is your decision-making process there? You said routinely.
Yes, every case, always.
Always. Okay. So when do you move? Another question is, when do you move from a LAC 20 to LAC 30, or what is your
good question? Yeah. So very, very rarely do I use a 30. I only use a 30 for those huge, super strong rugby players with massive bones, which is very rare. And I use it in revision cases, but not all revision cases, only those, big, strong type rugby player sorts, because a lot of the time with the revisions, it's not the ligament that's the issue. It's normally a biological issue or low-grade infection or something like that.
So you routinely use the LAC 20, right, for male or female patients, correct?
Well, there isn't a smaller one, so yes, routinely. And that's a good point again, from a development point of view, to look at a smaller option.
So you would think for women, maybe, or maybe some population?
I think definitely needs to be modified for smaller people and women, yes.
Okay, all right. Next question, is there a risk of over tightening with infraclavicular compromise?
I don't think so. So, well, yeah, the answer is yes. But then that's why when you're reducing, and it's very rare, but you do sometimes will push down and you'll completely close the coracoclavicular gap. Now that's bad. So obviously in those cases, you don't want that. You want to make sure that there is still a gap between the coracoid and the clavicle. So, when you're doing your reductions and your tightening, for me, the most important thing is that the acromion and the superior aspect of the clavicle are in alignment. So that's what you're aiming for. You don't want the clavicle below the acromion.
Thank you. And the last question we have from the audience is if this technique should be used routinely also for acute cases.
Yes. Okay, well, so yes, in my practice. So in your practice, maybe not. So the important thing is with any technique or any operation or any procedure or any implant you use, you need to be doing it regularly. You should be comfortable with it because, like I said, every implant has got failures, and need to know how to deal with those failures and know what those failures are. And the only way you get that is being familiar with the implant. So if you routinely do acute AC joints, like one of my colleagues does, then you can use techniques that are weaker, less invasive, and and that's fine. However, I very rarely, as you see, do acutes. And the majority of acutes I tend to be, well, majority are rugby players, but are athletes. So for those groups, I want to give them something that's very strong, that's anatomical, that allows them to get moving immediately. So that's why I use it. Also because it's the device that I'm most familiar with for those reasons. If your practice involves doing lots of acutes, then there are a number of other options that you can use. But if you are using one device very, very rarely, then I would say just use the one that you use all the time for acutes and chronics.
Mm-hmm. Yeah, we do have some more questions coming up. The next question is, how fast can patients get back to their normal activities with this method? And how would that compare with a clavicle hook plate?
So I'm not aware of a randomized controlled trial or comparison with a clavicle hook plate. When I've rarely used clavicle hook plates, they're for very specific patients, and we don't mobilize them straight away. So they're probably worse injuries and associated injuries. So I can't compare with the LARS ligament, because it's not rigid. It does give that flexibility, but it is incredibly strong. You can start moving them straight away. So in terms of return to, say, common again, rugby is about 3 to 4 months, return to play, to contact. In terms of professional athletes, manual workers, I'll normally say at least 3 months. But for office workers, they, usually about 3 weeks or so. I don't know if that answers the question for that person.
Mm-hmm. It does, yeah. Next question is, do you think that the LAC 20 has an advantage over the LAC 30 on the fact that the drill hole is smaller, 1 millimeter less? You think is that considered to be an advantage that you
Yes.
drill smaller?
Well, some simple answers: the smaller the hole, the better. Mm-hmm. Yes.
It's an advantage then. All right. Okay.
Yes, and the tensile strength is still 1,500 newtons, so it's more than you need anyway. So that's why I almost hardly ever use the 30.
Okay. So another question from Canada is, if you think it's necessary to ever augment the LARS ligament with an autograft.
Oh, yes.
Do you think it's needed?
Definitely. Oh, definitely for revisions. So revisions where there's poor quality tissue, I won't use allograft. I prefer to use autograft because I always believe the patient's tissues are best. If you want to use allograft, that's absolutely fine. I don't think that's an issue. I prefer autograft for revisions. For primaries, no. In a fit, healthy person, but you may want to consider a biological enhancement in primaries for example, somebody is a smoker or who has poor healing potential. Absolutely. In surgery, one of my bosses always taught me, if you think about it, do it. So if that surgeon's thinking about it, he should do it. Mm-hmm. He doesn't need to do it for standard normal cases.
Thank you. Next question is, could you please, revise a little bit your rehab protocol?
It's very easy. They have a sling for comfort for a couple of days, and then they can start active movement as comfortable, only avoiding forcing or stretching. And then progress to strengthening exercises immediately, so isometrics, progressing to resistance exercises, driving about 3, so I'll review them at 3 weeks, usually driving 3 to 4 weeks, no stretching, no forcing at any stage. I don't like that. Just focused on functional rehab that's relevant for that particular sport or function they need to do as comfortable. Very simple.
Mm-hmm. And the latest question, probably the last one, unless there is someone that pops up, is can you also do a quick comment on the trajectory? What angle do you drill the tunnels? And don't you struggle pulling through the ligament through the medial tunnel? Is that a challenge for you?
Everything can be a challenge. I mean, any operation, each step has technical challenges, and you have to have techniques and tricks and ways of getting around those challenges. So I can't say that is more of a challenge than any other step. There's challenges with all the steps. In terms of tips to help with that part of it, so the angle should be anterior superior to posterior inferior. In terms of the actual angle, more vertical than horizontal. So if you look at that study from China, they didn't say the angle, but if you look at their paper, it's probably roughly about 20 degrees if you want an angle. So, certainly no more than 45 degrees. In terms of passing the ligament through, so the tips there are, don't over drill the hole. So drill the hole, clear with a periosteal elevator under the clavicle to get rid of any soft tissue, then pass the wire loop through, and then use a strong needle holder underneath. You open it. Can you see me? I don't know if you can see.
Yeah, we can definitely see. Yes.
I can't see anything.
Yeah,
pass it underneath. So you go in and you open it, then put the wire loop in, and then close it, and then come out. And you'll feel it. You'll know you're in the wire loop, and then pull out. And then when you load it through, make sure you don't leave too long a limb on the other side of the loop, and you pass it through, so you just get it through, and then you'll get that little extra end out, and then you can just pull it out that way. I mean, just that's all I can say. If you can't find, so sometimes it's like arthroscopy, you can't triangulate to get that, to be able to do that. What you can do is take the guide wire that you use for the screws and pass that through, because it's hard, and then grab that. And if you try and pull on that, it won't come, but then at least you've got your needle holder in the right place to grab the screws. So you then take that one out, put the wire loop through, you're in the right place, and out you come. If That's the only thing triangulating. But don't go too horizontal, because if you go too horizontal, then, well, number one, you're completely off track, because I have seen that done before. And then you will struggle because you're then going posterior, not inferior, to grab the loop.
And also another question is, I assume that this surgery can be done fully arthroscopically, but can it be like minimal invasively?
Yeah, but what's the point? Why?
You don't see a benefit of doing small incisions?
Been there, done that, got the T-shirt. Remember, like I said, the CC ligaments is the only thing you can see arthroscopically. You've got to repair or reconstruct the AC ligaments, and you have to reef the deltotrapezial fascia. So to be able to do those things, you're going to have a reasonable size incision. So in acute cases, if you want to, in acute ones, do it arthroscopically, that makes sense. But if you are going to do an acute arthroscopic technique, don't use the LARS. There's much easier techniques to do a straightforward arthroscopic coracoclavicular ligament repair or reconstruction, if you're not going to repair the other parts. So I don't see the point. But yes, if you want to try and you want to do it mini open, go for it.
Okay. Well,
don't let me stop you.
All right. That was the last question, Professor Funk. We appreciate your time and your effort on the slides and on the Q&A session. Thanks again also for giving us the rights to record this session. We'll be able to spread it out to some of your colleagues that were not able to join at this specific time because of their practice of different reasons. And thanks again, and we stay in touch for the next session in the future.
Yeah, large thank you for so many people for joining from all around the world, and amazing questions, really good question. I hope they were useful, and I'm always happy to take any tips from anyone else as well.
Thank you very much again. We appreciate your support. Have a nice good afternoon. Good luck.
Thank you. Bye.
Goodbye, Professor. Goodbye. Thank you.